I'm Dr. Arnold Wheel, and I practice in Atlanta, Georgia. I practice non-surgical orthopedic medicine and pain management. Today I'm going to be talking to you about pain management, in particular the anatomy of injuries. As you know, chronic pain is very common and prevalent within our society. It affects more than 50 million Americans, and it's associated with a lot of different comorbidities, which makes it even more difficult to treat. These comorbidities can be things such as anxiety, depression, sleep disorders, and in fact, a lot of the medical costs associated with chronic pain is not only from treating pain itself, but also dealing with some of these comorbidities. And the financial impact is staggering. It's almost $80 billion annually. Chronic pain affects a large percentage of our population, and more than 40% of patients that do have chronic pain statistically are treated inappropriately or inadequately for their pain. Musculoskeletal pain is probably one of the most common types of chronic pain that we see in private practice. The prevalence of chronic pain in this population is between 15 and 30% and accounts for about 1 in every 7 patients visits to primary care physicians. And again, it affects 1 in every 3 Americans. More than 50 million Americans are affected, resulting in over 325 million physician visits per year. That's a lot of visits for chronic pain. The impact of chronic pain is staggering, and again, over 50 million Americans seek treatment annually for chronic pain conditions. Nearly 25% of these patients that actually have chronic pain change healthcare professionals during the course of their treatment. And this is fairly significant. And the main reason why they continue to change healthcare professionals is because they feel like they're getting inadequate pain treatment. There's really a need for a more multidisciplinary approach to treating chronic pain. But often in our communities, what we see are quote, pain clinics that really focus on one area of treatment. For example, there's a lot of so-called pain clinics that all they do are injection therapies. There's other pain clinics that really focus on medications. And then the treatment of chronic pain really encompasses a multimodal approach, including injections when necessary, pharmacologic intervention, and oftentimes other types of therapies like physical therapy, occupational therapy, and of course exercise for strengthening and stabilization for long term. So again, all these factors really come into play and are important in preventing our patients from jumping around from doctor to doctor and sticking with one pain care professional. So there really is a need for understanding of this global impact of chronic pain, and again, how it affects not only our society, but how it affects the patient that actually has chronic pain. So we talk about pain. I always like to emphasize there's a difference between acute pain and chronic pain. And really in my practice, we see orthopedic injuries and we see a lot of acute pain as well as chronic pain. So every patient I see, though, comes in complaining of some type of pain, so I'm always doing pain management. But there's a difference and a different approach in whether we treat acute pain versus chronic pain. Acute pain is defined as pain that comes on quickly, it can come on after some type of injury or trauma. It can be severe in nature, and it can come from different sources. It can be from a nociceptive type of injury that may cause pain. It can be from a post-operative procedure. But typically acute pain is self-limited, tends to go away with proper treatment over a short period of time. Now it's different than chronic pain. Chronic pain is really acute pain that gets out of control and doesn't respond. Chronic pain is pain that persists for an inappropriate or a prolonged period of time. A lot of providers get hung up on, well, 3 months is less than 3 months is acute pain, more than 3 months is chronic pain. But I don't really like to define pain, acute versus chronic, based upon a numerical value. There is kind of the accepted 3 months or greater, it's developing chronic pain. But, I really like to think of pain that's chronic as pain that, is really persisting longer than you expected it would. So for some injuries, you would expect the pain to resolve quicker. And when it doesn't, continues to persist, that's when it's becoming chronic, and that's when we really have to intervene to try to treat it aggressively to keep it from becoming a chronic painful condition. But typically, chronic pain develops over time. It lasts longer than expected, and again, it's associated with a lot of the different comorbidities that I mentioned before, and I'll talk about later on. Let's talk about pain. And again, most of chronic pain tends to fall within the musculoskeletal pain syndromes. Again, musculoskeletal pain is very common, probably the most common type of pain that we see in an orthopedic setting. So the most common musculoskeletal pain syndromes are those associated with the low back, and we can talk about low back pain and all the different areas of low back pain and how that's affected. Myofascial pain, soft tissue pain, often associated with muscle spasms. Cervicogenic pain and headaches, very difficult sometimes to treat headaches. It's a very complicated a medical condition that can present with a lot of pain. It can become chronic. Cervical dystonias and spasticities. These are the types of musculoskeletal pain syndromes that often cause acute and chronic pain. Now, back pain, I like talking about back pain because that's the majority of what I see and really specialize in. And back pain is very tricky. It's not as straightforward as a lot of other medical disorders that we see, especially in a primary care setting. The challenge with back pain is that there's a lot of causes of back pain, and there are multiple anatomic sources that can actually contribute to the back pain. And I'll talk about some of those today. And in addition to the multiple anatomic sources, there really is no standard method for categorizing, diagnosing, and really how we treat pain syndromes. And I'm sure if you look in your own communities, you could probably identify 4 or 5 different practices that treat back pain, and many of them may have different approaches. And again, I'll talk about some of the approaches, but the treatment protocols tend to vary from rest, exercise, to physical therapy, spinal manipulation, oral medications, injections, and in the worst case scenario, of course, surgery. So there's a lot of different approaches. There's no standardized algorithm, no standardized treatment, and it makes back pain much more challenging because you really have to dial down and get your diagnosis and be an accurate diagnosis before you can really start to treat. Another type of pain, very common, we see this in practice all the time, is myofascial pain. Myofascial pain is really soft tissue pain. We really are talking about trigger points and pain, tight areas of muscle bands that cause pain. And again, the diagnosis hinges on these painful muscle trigger points. And the trigger points are active trigger points that produce persistent pain. So for example, when we press on a trigger point is an area of muscle, a hypertonic area of muscle that when you palpate or press on it, it radiates pain into a very well-defined area of the body. So for example, trigger points in the neck, when you palpate that area, it would cause pain in a very consistent pattern, and that's a trigger point. And they can be active where it produces pain on a persistent basis, or the trigger points can actually be latent, and so there's no pain unless that area is really palpated. And there's a lot of different treatment approaches to trigger points and myofascial pain, ranging from medications, in particular muscle relaxants, anti-spasticity medications, and then also trigger point injections, soft tissue release, myofascial release, and physical therapy. Now, talked a bit about cervicogenic pain and about headaches. Cervicogenic headaches, very common, especially after an acute traumatic injury like a motor vehicle accident, some type of flexion extension accident. Again, the headache typically will originate in the tissues of the neck. It can be caused by injuries such as cervical spine, again like a whiplash injury or a fall. And again, there's lots of different approaches to the cervicogenic headaches, from medications, different types of medications, to different types of therapies, again, to different types of injections. So we'll talk about some of those as well, but what you're seeing is this common theme of soft tissue pain treating with a combination of medications, physical therapy, and often different types of injection procedures. So now that we've talked about some of the causes of pain, in particular chronic pain, how do you assess the patient? And that's really the key. And as physicians, when I talk to physicians about chronic pain, the first step I like to really emphasize is, the most important aspect is really the collection of all the information. Obtaining a history and reviewing the medical records. And a lot of times, by just talking to the patient and really focusing on the history, you can get enough information that can really give you your diagnoses. I'm not saying you don't have to examine the patient, because that's certainly a very important part of the evaluation also, but the history is vital. So collecting the data is something that a lot of times physicians don't pay enough attention to. In particular, pain history. Again, we're talking chronic pain patients, so they're really focused on their pain. How long has the pain been there? When did the pain first start? Okay, what types of things have made the pain worse over the years? What types of things make the pain better? Again, all the factors that impact that pain are important to know for us to have a better idea of where the pain's originating, but also how we're going to go about treating that pain. So again, collecting the data, finding out about the history, both chronologic and also the intensity and nature of the pain, very, very important. Then defining the pathophysiology. It's too easy, and all the time I see somebody comes in with pain, and physicians tend to just start treating the pain without really having a good understanding of where the pain's coming from. All right? not really very effective from a long-term perspective. So the next step really is to define the pathophysiology. Let's take back pain, for example. Back pain, as I said, it can have multiple anatomic sources of back pain. It can be pathophysiology, it can be in the intervertebral disc, it can be in the bones and joints, it can be an inflammatory process, it can affect the nerves, or it can be strictly muscles and soft tissue. So knowing the pathophysiology, knowing where the problem lies is really important, because if it's a disc problem contributing to back pain, contributing to chronic pain, then my treatment is going to focus on correcting the problem, which has to do with the disc. So I'm not going to be as focused. We don't want to just treat the symptoms. I need to really define the pathophysiology, know that it's intervertebral disc, and treat the disc. If it's muscular, my approach is going to be different. For example, I'm going to select different types of medications to use in this patient than I would if it's a disc problem. So again, defining the pathophysiology is very important to determining the approach to treatment that you're going to make. Once you have obtained all this information, integrate the findings. What I mean by that is we know the pathophysiology, we have an understanding of the pain, the intensity of the pain, how it affects this patient's life. We need to put it together. We need to know the mechanism of the injury, and this will help us then to develop a therapeutic strategy. This will help us then to develop a therapeutic strategy on how we're going to treat our patient and how we're going to jump in and try to attack the chronic pain. And again, I said in the beginning, it's a multi-modality approach. So we're not going to focus on just injections or just throwing a bunch of medications at the patient or just sending them off to physical therapy. Again, it's a combination of all the above. It may include some medications, it probably will. It may include physical therapy, although for chronic pain, the indication of physical therapy is not on a long-term basis, but for very specific, well-defined periods of time, depending upon the type of pain. And then finally, in some instances, chronic pain, when they have acute exacerbations or certain types of pain that we need to address more suddenly, we'll consider therapeutic injection procedures, and I can talk about those as well. Okay, so I mentioned defining the pathophysiology of the pain. Let me illustrate why that's important. As you can see over here, we have an example of neuropathic pain. Neuropathic pain is a very specific type of pain where there's an abnormal processing of the sensory input by the central nervous system or in the peripheral nervous system. So this type of pain, neuropathic pain, really involves the nerves. All right? So what happens is an altered structure and function of the nerves, and this can be caused by some type of damage or lesion in the nervous system. Nonetheless, our treatment approach to neuropathic pain is going to be much different. For example, I may be less inclined to use opiates to treat pain and more inclined to use some of the medications that really are very effective and been shown to be effective for neuropathic pain, such as Neurontin, Cymbalta, or Lyrica. Those are some examples of drugs that really are targeting much more neuropathic painful conditions. Nociceptive pain, again,